Here the patient of rheumatoid arthritis shows the swelling, joint swelling, tenderness and limitation of motions in the joint. It mostly involves the distal small joints and also some large joints. As you can see here, there is a swelling in the knee joint also. We are comparing here right side with the left side of the knee joint. The right side is more swollen, and also comparing the foot part. Actually the patient is under treatment, so most of the clinical manifestations cannot be seen, but there is a pain in the movement, which is the most common manifestations. And we are comparing here the range of motions of the joint movements. Mostly it involves the wrist here, the wrist joint. See the left side comparing the right side. The right side is not moving properly, having limitation in the motion. Also involved in the elbow joint. There is a painful movement. That's why patient is not able to carry on the proper movements. Comparing the right side with the left side also. Now the knee joint also. Patient actually came with the joint swellings and pain. So friends, we have just seen the patient of a rheumatoid arthritis. So now we are going to discuss the clinical aspect, means the theoretical aspect of the disease. So the rheumatoid arthritis is actually a chronic autoimmune multi-system disease having inflammatory arthritis and systemic manifestations. The patient usually presents around 40 to 50 years of age, having female predominant, but we have also seen the patient of a male in our previous video. That means male can also be affected, but mostly it's a female predominant disease because it's an autoimmune disease. It presents with the joint swelling, morning stiffness, with the pain in the joints, and there is a limitation in the range of motion. And please note here that the appendicular skeleton is most commonly involved as compared to axial skeleton. Appendicular is more than the axial. So we can see here the mostly it involves the joints like metacarpophalangeal joints, the proximal interphalangeal joint. Note here that the DIP is not involved in the rheumatoid arthritis. It's a very high yielding point. The DIP is mostly spared in the rheumatoid arthritis, unlike the osteoarthritis in which there is a involvement of the DIP also. So now let's move on towards the pathogenesis part of the rheumatoid arthritis. Before that, we have two main points to be noted here, the high yielding points, that there's a susceptibility gene for the rheumatoid arthritis which is known as the HLA-DR4. It's a very important question in the PG examination. Never forget this gene, that is the HLA-DR4, which is a susceptibility gene for the rheumatoid arthritis. And one more point we have to note here, that the rheumatoid arthritis, it's an autoimmune mechanism, and mostly it is a type 4 hypersensitivity. Very important point, it's a type 4 hypersensitivity. So now what we have is there's a three phase, mostly the initiation phase, the amplification phase, and the chronic inflammatory phase. So in the initiation phase, mostly it is due to the non-specific inflammation. And note here the initial site of disease is the synovial membrane. See, you can see here in the diagram, there is a synovial membrane which is affected mostly in the joint articular part, the synovial membrane. In this, all those reaction in infiltration of the T cell, macrophages and other neutrophils are occurring that causes the damage and deformity in the joints. So in the initiation phase we have a non-specific inflammation, and then next we have a amplification phase. In the amplification phase it is mostly because of T cell activation. The T cell activation causes the such all those infiltration, all those cytokine to be released that causes so much damage towards the membrane of the articular part, that is synovial membrane, which is known as the synovicite accumulation. All those dendritic cell, see here the diagram, T cells, B cells, angiogenesis, neutrophils, it is all occurring here. And then last is the chronic inflammatory phase, which is occurring because of the cytokines release. The most important to be point here noted is the cytokines are interleukin 1, TNF alpha, and the interleukin 6. These are very high yielding points. Never forget these cytokines, these are very important. So these are all because of these cytokine release, which is causing the immune mechanism and immune destruction and deformity of the joints. So now let's move on towards the clinical manifestations of the disease. In the clinical manifestation, as we have seen here that mostly the synovial membrane is involved. The most important point here noted is in the synovial membrane, the morphologically and the gross appearance, there is a pannus formation or the villi formation because of the infiltration of the immune cells that causes the so much inflammation, granuloma formation, angiogenesis. So there is a villi and the pannus formation, as you can see here. These are all those the things. This granuloma, white part, that red part, reddish. These are all the villi or the pannus formation, which mostly causes the eruption and the destruction of the articular membrane. It's a see the histopathological histopathology. The histology shows these are all pannus with the granuloma and the infiltration along with the infiltration of the T and the B cells all here inside this villi. So let's discuss about the involvement of the joint. In the involvement of the joint, we are comparing here with the rheumatoid arthritis with the osteoarthritis. We have already talked about in the rheumatoid arthritis the DIP is spared, which is very important and high yielding. The DIP is spared. So it mostly involves the PIP, that means the proximal interphalangeal joint, the metacarpophalangeal joint, the wrist joint, elbow, shoulders, knee joint, ankle, and all those metatarsophalangeal joint, tarsal joint, intertarsal joints. The DIP is spared. Also note here the axial skeleton not involved, but only the atlantoaxial part is involved. In the axial part, we have only the atlantoaxial joint is involved. The atlantoaxial joint is involved in the cervical region. So mostly the cervical vertebrae are involved, that causes the further disease manifestation that we will learn just now. The clinical manifestation part next is, so we have divided the clinical manifestation as the articular, and the extraarticular part. So what we have here is articular and the extraarticular part. So the articular part is here, mostly the most important terminology here is the rheumatoid hand. So the rheumatoid hand is all those, as we have talked about, there's a deformity in the joint because of the immune destruction. It causes because of immune destruction. So because of immune destruction, and mostly we see there is a small joint involved, most common as compared to large joint. So small joints mostly are the hand part and the foot part. So because of the immune destruction, there's a deformity, and we can see it as like a rheumatoid hand, which can be seen as a Z deformity. We have a Botanius deformity, we have a swan neck deformity, the Botanius part. So these are all those rheumatoid hand features which can be seen. We also have a manifestations of the foot and the ankle part. So in the foot and the ankle part, we have a broadening of forefoot, we have a bunion formation, that is known as a hallus valgus deformity. We have a broadening of forefoot. So the broadening of forefoot, there is subluxation of the toes at the metacarpophalangeal joints. And note here that the radial deviation of the wrist and ulnar deviation of the finger is the most pathognomic feature, which is known as the Z-shaped deformity. So the Z-shaped deformity is actually the ulnar deviation of all the fingers, which is the pathognomic for the rheumatoid arthritis. So now next we have extraarticular manifestations. In the extraarticular manifestations, we have, that is the systemic involvement is there because of the it's the autoimmune disease. So autoimmune disease also involves the other system, which is the cardiovascular system. In the cardiovascular system, we have a vasculitis that is known as rheumatoid vasculitis. So there is a vasculitis. In the heart, we have a pericarditis. So the pericarditis, and we have the pleural effusion, we have a coronary artery disease due to premature atherosclerosis. So all these are the cardiovascular manifestation. And note here, the most common cause of death in rheumatoid arthritis is because of the cardiovascular manifestations. It's the most common cause of death in the rheumatoid arthritis patients, which is the cardiovascular manifestations. Next we have a neurological manifestations. The neurological manifestation involves the peripheral neuropathy, the cord compression. The cord compression is because we have already talked about there is atlantoaxial involvement. So there is an atlantoaxial subluxation which causes the cord compression and the damage towards the cord. Also there is a nerve entrapment. The other system involves the eye. We have a skin. Note here the renal involvement is very less or either nil. Renal involvement is not there. It may be involved because of the all those drugs we are using like gold, penicillamine. It can be because of drug therapy, but usually it does not involve the renal part. So now let's discuss towards the treatment of the rheumatoid arthritis. The treatment involves the DMARDs. The DMARDs drugs are disease modifying anti-rheumatoid drugs. We have the classical DMARDs and the biological DMARDs. The synthetic drugs that were used previously, chloroquine, penicillamine, azathioprine, gold salt, leflunomide, methotrexate is the most important previously also and now also for the treatment of this disease. Methotrexate is very important. Along with this, we are also trying to give in the steroids for the immune suppression so that the disease and the immune part can be suppressed. Now we have a biological DMARDs. The biological DMARDs are very important for the PG point of view also because they are latest drugs and and because of PG point of view they are very asked. So please carefully listen this and learn this by heart because they are mostly asked. These are latest very effective drugs but they are very costly. So we have a TNF alpha inhibitors like adalimumab, we have cetrolizumab, we have etanercept, infliximab and the golimumab. In the interleukin 6 we have tocilizumab, we have sulimumab. In the interleukin 1 receptor antagonist we have anakinra. We have a co-stimulator inhibitor, we have the known as the abatacept. One more drug you can note here is the anti-CD20 inhibitor, that means the CD20 inhibitors, that is known as the rituximab. So the rituximab is one of the most important drug that is used in the biological DMARDs. So this is how we have discussed the clinical case of the patient. We have discussed the pathogenesis, the clinical manifestation and the treatment part. Thank you very much.